Hello, everyone, and welcome to Ortho NorCal educational webinar series. We hope everyone is staying safe and healthy and enjoying the sun outside. My name is Leah Rutunov, and I will be the moderator for today's webinar. I'm honored to host this event together with Dr. Nicholas Abidi, foot and ankle orthopedic surgeon at Ortho NorCal, and Caleb Miraglia, doctor of physical therapy at Ortho NorCal Physical Therapy Office. Today's webinar topic is the common foot and ankle problems, and it's intended for patient education. We will have Q&A session after the presentation, both presentations, I'm sorry. So be prepared to send your questions to us using Q&A or chat buttons on the bottom of your screen. If you have any additional questions after the webinar, you can always email us at info@orthonorcal.com or call the office directly at 408-412-8100. With all that being said, I'd like to welcome our first presenter, Dr. Abidi. Welcome, Dr. Abidi.
Hey, Leah, thanks. And thanks everybody for coming in and listening today. We'll get started here in a second. So what we'll do is we're going to go through my talk. We'll have some question and answer, and then I'll turn it over to Caleb. And Caleb will elaborate and give you guys a chance to talk about more questions in the same area and a little bit more details with one or two diagnoses that are very common. And Caleb can answer a lot of these things too, or reiterate or reinforce what we've talked about also. Caleb works with us as a physical therapist. I'm an orthopedic surgeon, so I see hip, knee, and ankle issues. So I specialize in lower extremities. So I do hip replacement, knee replacement, and ankle replacements, and then complex foot and ankle surgery at Ortho NorCal. I was formerly a professor at Thomas Jefferson University in Philadelphia and at the Rothman Institute in Pennsylvania. And I worked there from as a resident from 91 to 96, and then as an attending from 97 to 2000. And I was director of orthopedic medical education. And I had 2 research labs there. So I currently practice orthopedics, and I also teach and lecture, and I'm an editor for a couple of journals and work with peer review process with our national processes. I've been practicing in Northern California now for over 20 years. So today we're going to talk about common foot and ankle issues. So we'll get started with that. So common problems we'll go through as a little bit is bunions, hammer toes, Morton's neuroma, plantar fasciitis, ankle sprains, posterior tibial tendon issues, and then ankle arthritis and some diabetic foot and ankle problems as well. And people generally take walking for granted. There are 26 bones and 40 joints in the foot and ankle complex. People take about 10,000 steps per day, we say, hopefully, and walk about 70,000 miles in a lifetime. Walking is generally taken for granted unless there's a problem that shows up. And this has been the way, same slide I've used now for almost 20 years, that seems to be true, is that all of a sudden people come to a head and then they have to rush in to get something done. So hopefully we'll try to identify some of those things ahead of time before they get to be out of control, and they could be treated potentially non-operatively or with very minimal changes. So what's the best way to prevent injuries? It's this shoe. So this is like the ultra sort of ideal shoe for most of us, that if we could wear this all day, we'd love to do that. And thankfully, some of the dress shoes now are built like this as well. But this is one of Nike's competitive shoes, which has a full gel sole and a carbon graphite and kind of a wide upper. And the reason why we show this one is this is the sort of ultimate shoe that would help to prevent injury, both with athletics plus day-to-day walking. There are many different forms of this shoe by many different manufacturers, but the idea is it's got a rocker bottom built in, plenty of cushioning, and a good lace-up component. It's not a slip-on. This generally prevents or treats most complex foot and ankle issues, frankly, other than fractures and deformities. And even in the rehab phase, this helps people to rehab from those injuries. So when people come in, we give you a shoe and orthotic list generally. If we haven't done that, you can ask us for one, which says what type of foot that you have, and actually what shoe might work for you. This is a real simple solution, but there are 3 different types of shoes, one with a high arch, a low arch, and a medium arch. And we sort of guide the treatment towards the shape of your foot according to what your diagnosis is, and then what might work the best for you as well. So when we look at the different shoe components, they have a wide forefoot with a lot of cushioning, or a narrow forefoot if you need it, and then a narrow heel with cushioning. Asics and Brooks and New Balance now have 3D foam printing. So does Nike, and they've 3D printed the foam that's in the heel. And we look at the alignment of that and give shoe recommendations based on your problem individually. Other shoe manufacturers now, Neo, Dansko, Johnson Murphy, and Abeo, as well as Atrex are actually making shoes which match some of the recommendations that we're recommending. And according to what individual problems are, you can sometimes get a shoe that treats that issue. If you're a heel striker, 4-foot striker, have a narrow foot or a wide foot, your shoe can be geared towards that issue. But generally, cushioning is a really good thing. So when you look at the different parts of the shoe, the running shoe has the upper, which is the last, and then the shape of the shoe is the way it's shaped on the bottom. And this is the shank part. So we mostly like a stiff sole, but want this material to be softer to absorb shock, except maybe in tennis or in wet surfaces where someone's using a cross-training type shoe. And they might slide. Most walking applications and running, we want someone to have a soft sole with a cloth upper that doesn't put pressure on their hammer toes, their toes, or, it isn't too confining generally. So we divide feet up into a high arch, which is called a cavus foot. This is looking from the bottom of the foot like this, bottom of the foot. So a high arch called a cavus foot, a normal arch, and then a flat foot. And accordingly, we might use a neutral shoe for this person, a very flexible shoe, and then a neutral shoe or a stability shoe for this person with a little bit of arch, and then what's called a motion control or a stability shoe for someone with a really flat foot. And this is looking from the back, and that neutral foot, which is here, and then the overpronated foot and the oversupinated foot. Pronation means flat foot, supination means high arch. So anyway, we guide the people towards the type of shoe that works the best for them. When people have a high arch, they don't absorb shock well. So they really need a shoe that absorbs shock really well. When people have a really flat arch, they need some arch support and some shock absorption. And in neutral, they can have a mild support or no support and do okay. So those are kind of the shoes are divided up into neutral, medium support, or high support. And this is what we look like. So when someone has a straight last type shoe, this is a neutral shoe. This is good for someone who has has a really high arch with no shock absorption. And then these other shoes can be made accordingly to support the foot. And that's sort of the way shoes are divided up a little bit. So this stuff's going to be on the recording. You can access it later on and take a look at it too. So this is that for people who have a flat foot. We want them to have sort of a semi-curved arch support. For overpronators or basically a really flat foot, a little bit more support. And then for supinators, something that actually absorbs their shock, okay? Prevents them from rolling on the outside of the foot. You would think with someone with a really high arch, wants a high arch support, it's actually the opposite. We don't want them to roll on the outside of the foot and get a stress fracture or damage their peroneal tendons. We want them to actually have some support, prevent them from rolling their foot sideways. So it's a different type of support. When people have lacing problems and they have a high arch, we can alternate their laces so that they don't put pressure in certain places. We can skip the arch area at the top of the arch and avoid that altogether or put less pressure. So when someone has a high arch, we don't want to put this crisscross pattern because it puts too much pressure on the top of their foot, makes the shoe too tight. This lacing pattern, a high arch, takes the pressure away from the top of the foot and makes them not have numbness per se, okay? And when you look at your shoe, if you're wearing a heel or a shoe that's really snug and you draw your foot diagram on the floor and put the shoe inside that diagram, if your shoe is like this and your foot's beyond, it's overflowing or spilling out of the shoe, means your shoes are too small, shoes are too tight. And that can be the first place to start with forefoot issues like neuromas or forefoot problems in general. So 2/3 of the women in the 80s and 90s used to complain about shoes as a primary cause of their problems. It's a lot less now. The shoe manufacturing is better and people are starting to recognize these issues and they're not going for these crazy tight high heels on a regular basis. So when someone has a bunion, that can generally be an acquired bunion from shoe wear. When we introduced shoe wear to Asia in the 50s and 60s with the Americans, that's when they actually started getting forefoot issues. A lot of people didn't really have foot issues till we started introducing our Western shoe wear. And that a bunion means that the knuckle widens here, the big toe comes to the inside of the arch and the end of the big toe stays back where it was because there's a tendon here that holds that in place. And there are 3 different degrees of bunion where someone can just have a bump, where they have this spread, which is mild, or a big opening where the ligaments at the top of the arch give way and the foot widens right here. And that's called an increased intermetatarsal angle, meaning between these 2 bones. So hallux valgus is the same thing as a bunion. Your insurance company wants to see the word hallux valgus utilized. And if it's greater than 15 degrees here, that classifies something that qualifies for surgery. When people present their teenage years, that's something they were born with. When people present older, it's due to shoe wear and just aging. And so we generally try to get them into shoes and orthotics that work first, that are over the counter, real simple solutions before entertaining anything surgical. So someone with a bunion, we want to get them in a shoe that doesn't put pressure on their knuckle. And this seam is really tight leather, not a cloth upper. It's a cross-training shoe will put pressure on that bunion and create a blister. So we get the pressure off of there, a little bit of arch support, and make sure that that cloth upper or the soft deer skin doesn't have a seam that rubs in that area. That generally gets rid of about 2/3 of the people's forefoot issue. So there are about 100 different type of bunion operations. We address it at the apex of the worst deformity. It can be down here or generally up in the arch, or here is shown in the right diagram. Just depends on the patient. And the patient, it's a same day surgery outpatient. They come and go the same day, but can't put weight on the forefoot for about 6 weeks, no matter what we do. They have swelling for 3 to 6 months. It's not a minor operation. People get better faster from total knee replacement, total hip operations than they do from forefoot operation. So this is someone with a bunion pre-op, and we've actually cut the bone up in here, the knuckle, and shifted it over on this diagram on the right, and corrected it at the apex of the deformity, and then put a pin in temporarily. So that pin's temporary, the screw is permanent, and got these two bones called the sesamoids. We brought the knuckle over to them because this knuckle was out of place and the sesamoids were in the right place. So we reduced this angle, gotten things straightened out without just one cut, not a lot of different bone cuts, and corrected that deformity. Hammer toes are what happens when people start to get pressure sores on the top of the toes and it starts to get fixed. That starts off with a lot of pressure transferring from a bunion or just genetics, where people start to claw their toes up. Again, a shoe that doesn't put pressure on top is really, really important. And also sometimes putting a little pad in the arch, which I'll show you a diagram in a second, called a metatarsal pad, can bring that toe back down again. But we want to prevent pressure on the top from getting an ulcer. So these are those kind of pads we can use, called a Buden splint to hold it down with Velcro strap, or a little metatarsal pad that takes the pressure away and slows that down. And when you put this pad under the foot, it brings the padding back to the normal place where it should be and prevents further trauma to the knuckles. We want to stop this from getting worse by either using this device or using this pad. These are available in any sort of shoe appliance pharmacy store over the counter for a hammer toe. They work pretty well. The operative treatment involves taking away some of the bone and pinning it for 6 weeks. And usually it goes along with other surgeries. You have to protect that pin for 6 weeks or it'll bend or break. So what happens when you have forefoot pain? It's not a hammer toe. It can be a bursitis in between the knuckles called the Morton's neuroma. This would cause electrical sensation shooting into the toes without a whole lot of deformity. It's due to shoes that are too flexible and are too tight, and they create inflammation in the forefoot right between the knuckles, and that creates numbness and tingling and burning shooting to the toes. We put steroid, inject that area, and then do what I just showed you in that diagram with the metatarsal pad or the Buden splint, take the pressure away from the forefoot and make sure they're wearing good shoes to slow that process down. So again, same kind of thing, metatarsal pad, wider shoe, a little bit stiffer. That Nike shoe we showed is perfect for this. Doesn't bend a whole lot. It's got tons of cushioning. And if not, we got to take out the neuroma. Taking out the neuroma is pretty rare. The injections work, the shoes work, but if not, we got to take this thing out of the foot. So what happens when you have heel pain? Heel pain can be due to other causes like work, if you're a fireman or police officer, or on your feet a lot as a nurse or a waitress, or any job being on your feet, 10 to 14 hours a day, can result in pressure or overuse syndrome, where you develop a thickening or tearing of the origin of this tissue called the plantar fascia. That eventually causes irritation of a nerve and can cause tingling and burning in the heel. Doesn't have to have a spur. People call it a heel spur. It isn't always with a spur. Happens with first step pain in the morning, and then at the end of the day, people's foot can go numb. There are other diagnoses also that can accompany this, like ankle instability or Achilles tendon issues, obesity, diabetes. There are a lot of other things that can go along with it. We look for all those things. Make sure you don't have a loose ankle. Make sure you don't have an inflammatory condition. There's other things we look at. So the first treatment is for stretching and strengthening. So we stretch the Achilles tendon, and we recommend strengthening of the ankle ligaments, because sometimes an ankle instability will lead to this chronic foot issue where people turn their foot out, they start to tear the tissue in the arch. Over-the-counter inserts help, and then those shoes that we were talking about kind of slow the process down. And this type of a stretching helps, and then the cushioning helps a lot. So this is kind of the cushioning that we recommend. These are called Atrax inserts. They're softer, they're not hard. The other inserts tend to be really hard, and most people don't need custom orthotics. They do pretty well with these softer inserts. So sometimes if people have had pain for more than 3 or 4 months, we'll use a night splint to help them stretch out, and then a lace-up brace once in a while also. And if they don't get better, then we resort to surgical intervention, which involves decompressing the nerve in the arch if these two devices don't seem to work, along with therapy or a cortisone injection. We don't like to do endoscopic surgery for this because you can have problems afterwards that are difficult to recover from. Generally, these two issues get better with this treatment in most cases without surgery. The elliptical device is a non-impact form of exercise. It involves treadmills. It's good for exercise, making sure you're pointing your feet straight ahead. You get to stretch your Achilles and your calf. The other thing that's really good is the recumbent bike also. So the elliptical is good. The recumbent bike is really good. And then if we have to treat it surgically, this is what we do. We resect part of the plantar fascia open. We open up this tissue here, decompressing the muscle and the nerves that travel underneath. And that seems to help people if we have to do it, which isn't really that often. It's pretty rare. The most common injury that we're going to talk about here, injury-wise, is ankle sprains. Ankle sprains are 27 to 28,000 in the United States every day. One of the most common reasons for a trip to the ER is ankle sprain. And what happens is that this is the outside of the ankle. The ankle turns, the ligaments get stretched. That can result in trauma to other parts of the ankle, anywhere from the inside of the joint to the outside. And it leads to tendon problems if it's ignored in these tendons that run on the outside. And then when people fall when they're older, we ask them why they fell. And sometimes it's due to an unstable knee or an unstable ankle that was ignored 30, 40 years ago. So you want to treat these initially just with therapy and bracing and not ignore them, because only 5% will need surgery if they're treated aggressively in the beginning. And if they're not and they're ignored, a higher percentage need surgery. So the acute treatment is to get rest, ice, compression, elevation. Sometimes we use an air cast. Most of the time we recommend a lace-up brace like this, which is better. It's better at control. The air cast doesn't limit motion up and down, and this one does. And this will treat all ranges of ankle sprains. So this is a lace-up brace called an ASO. And then starting physical therapy as soon as possible and getting people walking if there's no fractures, really important. If people can't walk early on in the first couple of days, then we get CTs and MRIs and look for hidden fractures if the x-ray is negative and they still can't walk. When people have an ankle sprain like this, they should be able to get back to playing generally in 4 to 6 weeks if they treat it aggressively. If it's left to linger, it'll take 3 months to get better sometimes or result in surgery. So idea is rest, ice, compress, elevate, get the foot at 90 degrees in a brace like this, and try to walk on it if you can. If you can't walk on it, then get it worked up and have it treated. So if it isn't better, what do? We test the ankle for instability to see if it's loose with these various physical exam tests. It's not really that important in the initial phase, but with time, making sure someone isn't loose is very important. We bend the knee, we try to stress the joint out, see if it's still loose. And we compare side to side. We compare one side of the ankle to the other. Also make sure there's no nerve issues or fractures. So this is that front test is a sideways test looking at it. And if it didn't get better, we fix the ligaments. So if people aren't better within about a month or so, or if we find another issue, we might operate on it sooner. But generally, we tighten up the ligaments, and it's an outpatient surgery, make them numb from the knee down, make them sleepy. And then we have them walk on it as quickly as we can, about 2 weeks or so with a boot. And I reinforce my reconstructions with this thing called an internal brace. So that we found in our research, this prevents people from re-injuring in a large number of cases and prevents re-problems. And this with plastic anchor and suture material. So when we look at if people don't get better or they constantly sprain their ankles, they can damage the cartilage and go into arthritis. And that's called a bone and cartilage bruise. And that's what osteochondral means, is bone and cartilage bruise. And that's what this diagram represents. If you keep banging your ankle and turning it sideways, eventually the ankle doesn't recover. And it becomes like a over-ripened fruit where it's soft and it just doesn't get better. And then the cartilage on top dies. And that will show up sometimes on an x-ray or sometimes on an MRI. And we can prevent this by having really aggressive treatment of ankle sprains in the beginning to stop people from getting these lesions. These show up early, they can show up late. This is what it looks like on an x-ray when someone has it. Is this area is a hole in the bone, essentially, where the fluid has traveled in through the cartilage damage and created a problem there. And that's what it looks like on the MRI, where that lesion is soft on the MRI on the inside of the joint. And this is, several months afterwards, where someone didn't respond to the initial treatment, or they came in in a delayed fashion, said, hey, my ankle hurts. And we got x-rays and an MRI and saw this thing and decided what to do with it. And this got to be treated operatively. If it hurts, it'll just collapse and go into arthritis if it's left non-operatively. It's kind of like a cavity. So we used to drill up and put medicine underneath it a long time ago, or bone graft. Now what we do is we go from underneath with a cannula system and we inject something called liquid bone, which solidifies within about 5 minutes, this white material, and essentially lets us have the person walk on it in 2 weeks. It's a liquid bone substitute, which hardens up really quickly. And it avoids a lot of these other things like cartilage transplant, amniotic stem cell transplant. This works really effectively to prevent that cavity from collapsing further. So this is what it looks like in the operating room when we're targeting it with this device before we inject that material. So posterior tibial tendon disease is a problem of pain in the arch where people's arches collapse. This is the most commonly torn tendon in women over the age of 50. And it happens in the arch. Basically, difficulty going down steps is a strong indicator, unable to go up on your toes. This tendon stretches out in people over the age of 50. And it looks like this, where this person's left foot is collapsed like that. And that's kind of a really delayed thing to present with your foot like that, letting it go that long is a bad thing. We can prevent that from getting worse if people are saying early on and we put them in that lace-up brace I showed before to stop it from collapsing. And if it does collapse, then we got to get them in a bigger brace called an Arizona brace or do surgery on it. There's a lace-up brace again that we used before. And I did a lot of the engineering testing on this stuff 20 years ago and the other braces to show that in these various problems, it works well. And it's a really inexpensive, simple solution. And as opposed to an ankle sprain, where we might pull the strap outward, in this case, we pull the strap inward and support the arch for this problem in the arch. And it works really well. So this is the Arizona brace, which we have to use if someone has pain and swelling here and it starts to collapse, we'll use the Arizona brace. And if we have to fix it, this is what we do is we take that tendon, which ruptures, and debride it and transfer it, or we have to do fusion operations to support it. And then that takes a long time to get better. So we want to try to treat it non-operatively again. And about 80% of people, we can do that. This is what it looks like when we do a fusion operation. And again, we don't want to do this a lot, but if we have to, we can do it. That Arizona brace works great, but if it doesn't work, we go on to do this. So when people fracture the foot and ankle, you can fracture the ankle joint, you can fracture this bone in the middle, you can fracture any of these things, metatarsals. And so that this is kind of a diagram of the 26 bones and 40 joints in the ankle joint above that. So there's a lot of bones in the foot. Mostly when people have acute injuries, we recommend splinting in the ER, non-weight bearing, rest, ice, compression, elevation. If someone can't walk on it right away, they need to go to the ER urgent care facility. And less than a week or so, I got to decide if it's surgery or no surgery, because it helps us to fix things faster. Swelling can go down in 5 or 6 days, but if you're walking on a broken ankle, that doesn't really help us to make it better. So we want to kind of figure that out early on. If you can't bear weight on it, it needs to be looked at. And the earlier surgery is less pain and less deformity and less problems. I have a guy coming in this week who broke it 3 months ago, who didn't know he broke it. He thought he sprained it. That's going to be challenging for all of us to deal with. So if you have numbness or a fever, bleeding, increased pain, increased deformity, it doesn't look right to you, get in earlier rather than later. Because when people come in later, this is what happens. They get ankle arthritis. So this person has no ankle joint. So there's a trauma, was unavoidable perhaps in this case, but if you don't pay attention to it, you're going to get ankle arthritis. And ankle arthritis can happen after trauma, inflammatory disease, or it could be genetic from autoimmune things. This is what it looks like when we do ankle fusion. People are treated off of, they have to be off of for 6 to 10 weeks, and you lose 70% of the motion. It happens in diabetes, where we do most fusions nowadays. Most of the time we do ankle replacements nowadays. We've been doing since 96, but more commonly we do ankle replacements when possible. This is the ankle replacement that I use. I've been using them since 2007. I used an earlier generation from 96 forward, but this is one I've used now since 2007. I have good results with it and good, excellent survival rates, 95% at about 10 years. So patients are non-weight bearing with this thing for 6 weeks and then partial weight bearing for 6 weeks. And we use CAT scan planning tools ahead of time to get it done in a rapid fashion. They have a planning tool, get a CT. This is the surgical planning that we involve it, make it more accurate, and it goes in a little bit quicker and lasts longer. So diabetic ulcerations, when patients have diabetic ulcerations, type 1 and type 2, after 10 years, more than 10 people, more than people mostly develop neuropathy in their feet, and diabetic neuropathy can lead to ulceration or infection. And so that causes healing issues. But what happens with diabetics when they're not well controlled, they get a tight calf muscle, they start to get clawing of the toes. That leads to pressure points on the foot that they can't feel. They get ulcerations and infection there. So we want to try to prevent that through that protective footwear that we talked about a little bit. They have special footwear where we use these Plastisode inserts. These are available over the counter. That and running shoes decrease ulcerations by almost 50%. So we tell people to keep their blood sugars tight, shake their shoes out at noon, and change their socks every day. Don't wear the same ones over and over again. Look at their feet with a mirror and then put cream on their feet, and use depth shoes with no seams to try to take the pressure off of those areas and prevent ulceration. Sometimes patients will come in with a swollen foot spontaneously, normal looking x-rays. That's called a Charcot arthropathy. If they don't feel their feet, Charcot was a neurologist in the 1800s, and basically their bones can melt spontaneously while walking. And we worry about that because it'll deform, collapse, and go on to have an issue with ulceration infection where they can lose their feet. So when someone has a swollen foot like that, diabetic, and there's no ulcer on the surface, we always think about Charcot arthropathy. And so that's something that we don't want to miss. People have a Charcot disease, looks like this, where the arch collapses and dissociates. And amputations cost the patient time and money, obviously, and society money and time. And I developed a lot of plates and screw systems to try to fix these things. We don't have to use them very often, but we want to prevent this from collapsing like this and getting an ulceration right at this spot right here. So there's a couple different websites you can look at: the Foot and Ankle Society's website, our American Academy of Orthopedic Surgery website, there for resources. That's a diagram of the state of California. This is Santa Cruz. One of my staff made that for me a long time ago. So I thought you guys liked that. So we can take some questions now. I think, Leah.
Yeah, thank you, Dr. Abidi. I think I know I mentioned in the beginning that we'll dive into Q&A session after both presentations, but I know you have to get back to clinic. So we'll take questions for Dr. Abidi now, and then Caleb will follow up with his presentation and Q&A session for Caleb. So I do have a couple of questions to start with. What are the indications for total ankle replacement?
Yeah, so the indications for total ankle replacement are basically people who have bone-on-bone arthritis in the ankle joint that have failed injections and physical therapy. Generally, I do total ankles on people who are over age 50. In some exceptions, we'll do people in their 30s if they have no other alternative, or we think that ankle fusion might be detrimental to them. Sometimes we do ankle replacement in younger people for that reason, stop them from damaging other parts of their joint. In particular, we've done that. So if they have really good range of motion, people do much better with ankle replacement than fusion. If people are missing their motion, or they have unstable diabetes or infections, they're better having a fusion operation. So Leah, so I see the questions here. I can answer them.
Perfect. Go ahead.
I can answer these. I'll just take a look at them.
Sounds
so the other question is, if there's a culture test showing a mold in the toes, what do we suggest? Generally, we suggest for that kind of an athlete's foot infection to use Epsom salt soaks and Hibiclens or chlorhexidine solution soaks every day. So Hibiclens is chlorhexidine, and then Epsom salt soaks for about 15 minutes twice a day. Other question is it bad to walk around the house barefoot? Yeah, in general, it's really bad. If you walk around the house barefoot, you risk, number one, stepping on something, but creating a crack in your foot or getting an infection. And people don't feel things as they get older, and they don't realize it, but something going through the bottom of your foot can penetrate your bones or create staph infection or Pseudomonas infection. Those are always some of the hardest things to treat, and they can become chronic, actually. So we don't want you to do that. That's a dangerous thing. And then peroneal tendonitis. Someone's asking about peroneal tendonitis. So peroneal tendonitis are where the ligaments, the tendon on the side of the ankle or the arch can go bad. And when those peroneal tendons go bad, that can be due to circulation or repetitive ankle sprains, or a high arch that's collapsing and turning into something else with the peroneus longus tendon. So generally, we recommend for that is the lace-up brace, physical therapy, and making sure they don't have underlying instability or other issues like a dislocating peroneal tendon, making sure it's diagnosed properly. And sometimes it involves bracing, sometimes it involves surgery. MRI hasn't been characteristically perfect for peroneal tendons, but it's better. And we also have ultrasound in the office that we can look at peroneal tendons that I wrote some papers on a long time ago, looking at foot and ankle tendons. And so that there's combination diagnosis, physical exam, ultrasound, x-rays, talking about the mechanism of injury, and then MRI potentially to treat to really look at the details, see if it needs surgical treatment or non-surgical treatment. Any other questions you want to type in underneath there? What do we recommend to prevent ankle sprains? So we recommend that essentially preventative treatment. So a couple things for athletics. When people are starting season, like young athletes, they get really tall and skinny. And ACL injury prevention exercises and ankle sprain, just strengthening of the extrinsics and intrinsics, really important for training. And I think Caleb's going to talk about that a little bit more in his talk. He's going to talk about exercise and injury prevention and treatment. I think that's why Caleb's on. So Caleb's one of our doctoral level physical therapists at OrthoNorCal, and also involves sports teams and helps me to take care of some of the local athletes and sports teams. So I'll let Caleb take over at this point. I'm going to sign off because I got to start clinic pretty soon. But thank you very much for your attention, and I'll let Caleb take over.
Thank you, Dr. Abidi.
All right. Yes. Thank you, Dr. Abidi. Let me get my slides pulled up here. All right, awesome. Well, as Dr. Beatty said, my name is Caleb Moralia. I am one of the physical therapists over at the OrthoNorCal Capitola Clinic. Today, I'll be expanding a little bit on two of the common pathologies that Dr. Beatty talked about. I'll be focusing on the treatment of both plantar fasciitis and ankle instability, two of the most common ankle and foot injuries that we see here over at the clinic. All right, my objectives today for my presentation here are just to review briefly the anatomy and the pathomechanics of both the plantar fasciitis and ankle instability. And then I'll dive deeply into the treatment of both of these as far as the physical therapy treatment, what we will specialize in here, what you might be expecting if you come in seeking care for one of these pathologies. And then also I'm going to kind of apply the information and the topics that I discuss into a couple of case studies to kind of better give everyone an idea of what they might be expecting when they come in for not only their first visit, but treatment sessions following. All right, so throughout the presentation, I will be referring to information and treatment suggestions that were published by the Journal of Orthopedic and Sports Physical Therapist. These clinical practice guidelines that I will be referring to help provide physical therapists with a little bit of an outline as far as treatments that we might use for both of these conditions. Treatments are ranked on a alphabetical level here, A through F, as far as A being a strong level of evidence, something that we should or must do for our patients, something that we really want to implement in our treatment, all the way down to F being expert opinion, something that we may or may not be wanting to incorporate into our treatment. And we will discuss a little bit of the interventions that we use all the way from A to F, some things that you might be seeing when you come in for PT. So I'm going to start off by talking a little bit about plantar fasciitis, just a little introduction here. The plantar fascia is a band of fibrous connective tissue spanning from the penis or the heel bone all the way to the forefoot, and it attaches right at the base of the toes or the proximal phalanges. When you're weight bearing or standing, the plantar fascia helps support the medial longitudinal arch and it prevents it from collapsing. It also has a role in propulsion of the foot as we're walking from push off. And plantar fasciitis is just pain and structural changes, usually degeneration of the proximal insertion of the plantar fascia. Usually when we see this with imaging, we'll see thickening and degenerative tissue findings, more common than just inflammatory changes. So you may see people refer to this as plantar fasciopathy versus actual fasciitis, which suggests actual inflammation of the plantar fascia. So plantar fasciitis, as Dr. Beatty talked a little bit about, is one of our most common foot conditions that is treated by healthcare providers and is a common foot condition that we are going to see here in the physical therapy clinic. It occurs in approximately 2 million Americans each year and affects as much as 10% of the population over the span of a lifetime. It's both prevalent in athletic and non-athletic populations, and its highest prevalence is going to be individuals in the ages of 20 to 34 and also people over 75. So it spans quite a range of individuals in different age groups. Most commonly, we see this in runners, but we'll also see it in people who participate in frequent or overuse type sports, such as gymnasts, dancing, soccer, people who are putting a lot of stress through their lower extremity. And this is going to affect females a little bit more than males. Although the actual etiology and the pathomechanics are debated and not well understood for plantar fasciitis, there is a lot of research and evidence that suggests that there are definitive risk factors that lead to plantar fasciitis. One of those being limited ankle dorsiflexion range of motion, bringing the foot up. You know, if you're laying down, bringing that ankle and that foot towards your face. This could be caused by a past ankle and foot injury. A lot of times I'll see patients come into clinic who may have had an ankle sprain in the past, have lost some of that range of motion, didn't get that treated, and now have developed plantar fasciitis or heel pain. In addition, people who are non-athletic or non-athletes rather with a higher BMI have been shown to have greater risk of developing plantar fasciitis. As I talked about before, runners have a greater incidence of plantar fasciitis compared to other athletes. And that is one in part due to the greater ground reaction forces and the amount of exposures that those runners are going to experience. Specifically, people who start off, you know, running maybe a mile every day, and then they start wanting to train for something like a half marathon, and they gradually, or more so dramatically, increase the amount of running that they're doing at one time. Commonly, we'll also see people, say, join a walking group and go from not being very active to walking 2 miles a day, developing heel pain due to the increased ground reaction forces. Also, in our runners and our walkers, street running or running on a hard surface is going to predispose someone to plantar fasciitis rather than someone who's either running on a track or someone who runs grass. Also, spiked shoes, track shoes that don't provide as much support. Pes cavus or pes planus foot is also going to predispose somebody into developing plantar fasciitis. Also, those are non-athletes, say our laborers, are people working, say, in an assembly line or working construction, have been shown to develop higher incidences of plantar fasciitis, and that is mainly related to the time spent standing on hard surfaces, as well as the number of times that they're jumping in and out of machinery, out of a forklift or such. And also people who've been working from 4 to 7 years in a factory have been shown to develop plantar fasciitis greater than the normal population. So when someone comes into our clinic, here are some things that we are going to want to look at. We're going to have a detailed perspective of the person's overall lower extremity function, as well as their personal function, what they're having difficulty with in their normal day-to-day lives, as well as, say, a range of motion deficit. Commonly, we'll use self-reported outcome measures when the person first comes in. This kind of gives us a brief overview of what they might be having trouble with in their day-to-day life. In our clinic, we use the lower extremity functional scale. This has been shown to be valid in this population. We also want to look at the patient's history, specifically their symptom schedule. Commonly with people with plantar fasciitis, we will see people have more pain in the morning with the initial first steps, or initial first steps after sitting for a long period of time. So we really like to dive in and understand when this person is having pain, and that kind of helps drive our diagnosis. We also want to know some of the risk factors, which I just talked about. You know, is this person running? Are they standing on their feet for 5 hours at a time without a break? What are the shoes are they wearing? Have they had an injury before to this foot? We also take a detailed look at the positioning of the foot. Dr. Beatty talked a little bit about pronation or supination, with basically flat foot or a cavus foot, can lead to heel pain in our patients. We'll also go through some special tests. We will rule out any tarsal tunnel symptoms or any nerve entrapment that might be causing symptoms down the leg. In conjunction to that, we want to rule out any radicular symptoms that may be coming from the back or from nerve entrapment that could be causing these heel pains. We'll also take a detailed look at active and passive range of motions. As I said before, some of the risk factors to developing plantar fasciitis are decreased dorsiflexion range of motion. And then, as always, as physical therapists, we like to look at the overall lower extremity strength and function. So the person's ability to squat, a person's ability to negotiate stairs, are there any deviations in their gait that may point us into looking at strength in different areas, or understanding why this person might be having heel pain. Now, our key findings with someone who comes in with heel pain that would point us in the direction of plantar fasciitis versus another diagnosis are plantar medial heel pain, most noticeable with the initial steps after a prolonged period of inactivity or after a prolonged period of weight bearing, say standing on their feet or walking for a long period of time. Heel pain precipitated by a recent increase in weight bearing activity. Commonly, we'll see people with heel pain after an increase in the amount of walking they've been doing, running they've been doing, participation in sports. Reproduction of the reported heel pain with palpation to the medial heel, specifically at the proximal insertion of the plantar fascia at the calcaneus. A positive windlass test and negative tarsal tunnel tests, as well as other signs of possible peripheral nerve entrapment, as well as negative signs of lumbar radiculopathy that might be causing this pain. So we go through the examination, and now we've diagnosed this person with plantar fasciitis, and now it's time to get to work. So what are we going to do for this person? What are we going to focus on? Now, all these interventions that I have listed here have been given a evidence level A by the Journal of Orthopedic and Sports Physical Therapists. They are: one, manual therapy. So that's going to include joint mobilization, soft tissue mobilization of not only the plantar fascia, but also the surrounding soft tissue structures, specifically the gastroc and soleus, which are our calf muscles. And that's going to be specifically important if the person presents with limited dorsiflexion range of motion. Stretching has been shown to decrease the amount of pain in a short term from 1 week to 4 months that the patient may be experiencing. And then supplementing that stretching with a heel pad or heel cushion can also increase the benefits of this. A lot of times what I'll do is I'll give patients stretching for the gastroc and soleus, and I'll show you some pictures here in a bit, but also stretching the plantar fascia. So I have a picture here to the right here about a person rolling their plantar fascia with a lacrosse ball. This is an intervention that we'll commonly give people to do at home or in the clinic to help stretch out that plantar fascia. Taping has also been shown to be beneficial for immediate pain relief in patients who are demonstrating symptoms of plantar fasciitis. A lot of times I will use taping as an assessment tool. Patients who do well with taping, such as Lodi taping, which is a rigid taping for the arch to support that medial longitudinal arch, those people tend to do well with over-the-counter orthotics or custom orthotics. And that brings us into the next thing, foot orthoses. People who have plantar fasciitis tend to do well with a foot orthotic, whether that be over-the-counter or custom. And then night splints. The research has shown that a 1 to 3 month program of night splints for individuals with heel pain has been beneficial in decreasing the amount of pain that they may be having. So let's dive into a little bit of the interventions that you might see if you're coming to physical therapy. The first picture here is an instrument-assisted soft tissue massage to the plantar fascia. So I'm using a tool to stretch out the plantar fascia in this picture, and then what I might follow that up with is the second picture here, which is soft tissue or deep tissue massage to the gastroc and soleus complex, or the muscles of the calf, to try and improve the soft tissue extensibility there, and also to improve dorsiflexion range of motion. And then next, I might follow that up with this third picture here. This is an ankle anterior to posterior mobilization of the talus on the mortise. This mobilization is specifically used to improve dorsiflexion range of motion. Also, grade 1 and 2 mobilizations can be used to decrease pain. Now, taping, these first 3 pictures here are an example of the Lodi tape. So Lodi taping is a rigid taping that is meant to prevent overpronation, as well as supporting the medial longitudinal arch. So the athletic tape is actually pulled from a lateral to medial manner in order to support that arch. It is fairly rigid, and some people don't respond to this well. It feels a little bit too rigid for them initially. So in that case, I might use this fourth picture all the way to the right. This is a flexible tape, similar to what you might find in kinesio tape or K-tape. And this is just a little less aggressive. It also helps support the arch. This is something that I might use for someone who can't handle the Lodi tape, or for an athlete who might not want the amount of restriction that Lodi taping provides. As far as stretching, what you might encounter here if you come to physical therapy are this big picture on the right is gastroc and soleus stretching. Usually I'll have people hold these stretches for 30 seconds. We'll do sets of 3 to 5. And it's a lower intensity stretch, long duration hold. I'll also give people hamstring stretches. And then this top left picture here is a self-mobilization that I commonly use to help people regain dorsiflexion range of motion if that is part of their patient profile. So now we're going to take, and also some other interventions that can be used are changing the person's footwear. So if someone comes in with a flat shoe that doesn't have a rocker bottom, it doesn't provide a lot of support to the medial longitudinal arch, we may suggest something like a rocker bottom shoe. Specifically, I have a lot of patients coming in with Hokas now, which are a very soft cushion shoe, which incorporate a rocker bottom, and they also have a lot of ankle support. Also, shoe rotation for someone who's been standing on their feet for a long period of time has been shown to be beneficial. And something that us physical therapists really love to incorporate into a treatment session is strength training. Although this has a suggestion level of F, it's more of an expert opinion. Ask any physical therapist. Someone coming in with plantar fasciitis is going to receive some form of therapeutic exercise, whether that is a local exercise to the foot and ankle, such as improving the strength of the extrinsic or intrinsic muscles, supporting the arch, or providing stability to the ankle, or global exercises focused on hip strengthening or glute strengthening, which is going to help dissipate forces throughout the lower extremity while we're walking or performing sports. So let's take a look at a case study that a patient of mine who was coming in a couple months ago was experiencing some heel pain. This is a 60-year-old female. She presents to clinic with complaint of right heel pain. Symptom onset 2 weeks ago after joining a walking group and increasing the amount of walking that she was doing a day. She has pain with initial steps in the morning, and also after sitting for a long period of time at work. She has a past medical history of an ankle sprain 1 year ago, which she didn't receive physical therapy treatment for, and her goals are to be able to walk and exercise without heel pain. So when we go into her exam, we find that she has tenderness over that proximal insertion of the plantar fasciitis at the medial heel. Looking at her range of motion here, we can see that on the right compared to the left, she's lacking in both open kinetic chain, which is the foot off the ground, and closed kinetic chain, which is more functional for walking and for running. We're lacking in both of these areas compared to the contralateral side. She has a positive windlass test, negative signs of peripheral nerve entrapment or tarsal tunnel syndrome. And then over here at an assessment of her strength, she displays weakness of both plantar flexion and inversion, as well as weakness of the proximal muscles of the hip, which is something that we'll commonly see with most of the patients that we experience. Looking at this patient in standing, we can see that she has a flat foot or an overpronated foot, a little bit bilaterally, more so on the right, and that's demonstrated on the leftmost picture here. Looking at her footwear, we can see that her shoes aren't bad. You know, these are nice shoes. They're usually good supportive shoes, but they are just at the end of their life. She's been wearing these for too long. So a suggestion for a different shoe might be in the works. And then she also reports that when she's not wearing shoes, she really likes to wear sandals, but she wears Tevas that don't have a lot of support. And she actually brought these into clinic. So she wants to know if there's any other footwear that she can wear that may support the arch or decrease her pain. All right, so at her first visit, she's going to be sent home with an initial home program, or I sent her home with an initial home program of that needle wall mobilization that I discussed earlier. That's just to improve dorsiflexion range of motion, as well as stretch the gastroc-soleus complex. And then I'm going to give her standing gastroc-soleus stretches, low intensity, long duration holds. And then to address her hip strength and or lack thereof, I'm going to give her some supine bridging with some band resistance to incorporate the gluteus maximus and medius. And now her initial goals, and what I explained to her, is that we want to reduce pain and reduce the amount of stress that you're experiencing. So let's possibly look for a different shoe for you, or upgrade your shoe, something that has a rocker bottom, something that is a little bit more cushioned. So she decided to go with the Hoka's, a good rocker bottom shoe with a lot of cushion. And also, I suggested that she maybe look into the sandals called Chacos. They provide a little bit more of that medial arch support compared to the Tevas, the flat foot, or the flatter sandal. And so she took that, and that her homework was to work on getting those. I also educated her on no excessive walking or prolonged weight bearing over the next week, just to reduce the amount of stress that she might be experiencing on the plantar fascia. And before she left, I performed the Lodi tape and explained to her that this is temporary. This is something that is meant to support the medial arch. And we're going to use this as a screening tool to see if possibly our foot orthotics may be good for you. As we go through our treatment for this person over the next 1 to 3 weeks, she has pain reduction with the anti-pronation taping, with the Lodi taping. So we had that discussion then whether or not to pursue over-the-counter orthotics versus a custom orthotic. And eventually she decided to go back to her doctor to talk about orthotics that she might be able to use. She did have relief with a change of footwear. And then in clinic, we're going to work on improving dorsiflexion range of motion through our manual therapy, soft tissue massage to the gastroc-soleus complex, and also that instrumented assisted soft tissue massage to the plantar fascia, using both the lacrosse ball per se or the Graston tool. Therapeutic exercise progression for this patient. We're going to work on both the intrinsic muscles of the foot. These are muscles that help support the arch. Exercises for this may include tripod arch lifting, towel curls, or an exercise that I really like called toe yoga. And also, we're going to look at the proximal muscle strength. We're going to focus on clamshells for hip abduction, and then progress that to either side lying hip abduction, lateral band walking, single leg balance exercises, RDLs, and even closed kinetic chain hip abduction strengthening. But her overall goal was to be able to walk without pain. So over the next 3 to 6 weeks, as she's experiencing a reduction in pain, we want to get this person back to walking. So I always tell my patients that it's good to wean into this. So as Dr. Beatty said, we want to initiate exercise with a recumbent bike or an elliptical, and then progress that person through a walking program. So I suggested to this lady that, start with 0.25 miles, walk, take a break for about 5 minutes, and then walk back for a total of 0.25. Perform this over the next week. The next week, bump that up to 0.5 miles, 0.7 miles, and 1 mile respectively over the next 3 to 4 weeks. And this is all pain guided. If the person is having pain in the area of, say, 1 to 3 on a scale of 0 to 10, that's normal. I tell them to progress as tolerated. If that exceeds a 4, goes to 4 to 5, I tell them not to progress. Keep doing what you're doing and stay where you're at, but don't progress any further. If this gets above a 6, then it's time to bring that pain level down with rest, ice, compression, and elevation. And then by the end of this week's 6-week mark, the patient was able to manage her symptoms independently with the exercises we provided, which is ultimately the goal of physical therapy. But it's important to note that this is just a very general outline of what someone might experience when they're coming to physical therapy. People sometimes take a little bit longer to have relief, sometimes take a little bit shorter to have relief. But ultimately, our goal is to promote independence and independent symptom management. All right, so now we're going to switch gears a little bit here. We're going to focus at another big foot and ankle pathology that we see a lot in clinic, and that is lateral ankle instability, which encompasses acute lateral ankle sprains as well as chronic ankle instability. So acute lateral ankle sprains, as Dr. Beatty said, is one of the most common foot and ankle sports-related injuries, and is one of the most common reasons that people go to the ER. 40% of these lateral ankle sprains occur during sports and are more common in indoor and court sports such as volleyball, basketball. There's going to be a higher incidence with these sports compared to our field sports. Women are affected more than men, and then adolescents have a higher incidence of acute lateral ankle sprains compared to older individuals. And then of the individuals who do seek care, 6 to 11% of these patients are referred to a rehabilitation specialist or a physical therapist within 30 days of the injury. So we are seeing a lot of these people and at a pretty quick turnaround as well. So lateral ankle instability can be defined as the existence of an unstable ankle due to lateral ligament damage caused by excessive supination or inversion of the rear foot. Chronic ankle instability or lateral ankle instability is defined by the repetitive bouts of lateral ankle instability resulting in numerous ankle sprains. So chronic ankle instability, the prevalence is going to go up as we go into more higher level athletes. So our high school and collegiate athletes are going to have the highest level of prevalence, with female high school and collegiate athletes have experiencing chronic ankle instability more than males. So the mechanism of injury here for our acute lateral ankle sprains are rear foot supination or inversion on an externally rotated lower leg. So this is your very common lateral ankle injury, something that you see pretty consistently in basketball or youth sports. Excessive inversion and internal rotation of the rear foot results in a strain to the lateral ligaments of the ankle, which you can see here in this diagram. Now, if that strain exceeds the tensile forces of the tissues or of the ligaments, that's when our damage occurs. All right, and I'll talk a little bit about the grades of ankle sprains in a little bit. But let's look at the actual ligaments themselves. So our big players here are going to be the anterior talofibular ligament, the calcaneofibular ligament, and the posterior talofibular ligament. So these are all ligaments of the lateral ankle that are commonly injured with this inversion type injury. And these are I commonly refer to these as the static supports. The static support to the ankle are the ligaments. However, the dynamic supports are equally as important, especially when we look at chronic ankle instability, as well as the rehabilitation of ankle sprains. So the muscles that are going to provide that dynamic stability to the lateral ankle are the peroneus brevis and the peroneus longus, coming down and inserting here at the base of the fifth metatarsal. These muscles have an eccentric function in controlling the supination or inversion of the rear foot. In addition, the anterior compartment muscles, such as the tibialis anterior and extension digitorum longus, are going to work eccentrically to slow down the inverge or the plantar flexion rather aspect of the supination type injury. So these are all exercises that are all muscles that we're going to want to focus on with exercises later in the rehabilitation process. So ankle sprains can be graded on a scale of 1 to 3, with grade 1 lateral ankle sprains just being a stretch or microscopic tearing of the ligaments. 2 is partial tearing of the ligaments, as demonstrated in this picture here. Grade 3 is a full thickness tear of those lateral ligaments. Now, it's important to note that these lateral ligaments, as well as a joint capsule that encompasses the ankle joint here, are extremely innervated with mechanoreceptors, and these mechanoreceptors play a really important part to ankle proprioception and balance. So if we have someone with both an acute ankle sprain and or a chronic ankle instability, we're going to really want to work on balance, because the proprioception and the balance is going to be impaired due to the damage of the ligaments and the damage to those mechanoreceptors. All right, similar to the self-reported outcome measures that we saw with a person with plantar fasciitis, we're going to want to look at scales that give us a overview of the overall function of the person and what they're able to do out in the community with this injury. So the lower extremity functional scale, again, is the scale that we tend to use here in Capitola. But the Tampa scale of kinesiophobia and the fear avoidance beliefs questionnaire should also be implemented if there is a reason to believe that the patient is having some fear with getting back to sport, or a fear getting back to the workplace due to repetitive bouts of ankle instability. Another important examination consideration are the risk factors, such as a previous injury. We're going to want to take ankle swelling measurements with an acute lower lateral ankle strain and compare those measurements throughout the course of the treatment. Ottawa ankle rules, Dr. Beatty mentioned that we want to get imaging done if the person is unable to weight bear, and get that person on the right course of treatment if there is a presence of a fracture. The Ottawa ankle rules are something that a physical therapist is going to use in order to determine if someone needs to get imaging, say they come in direct access without a referral, or they haven't seen a doctor yet. The Ottawa ankle rules are going to help us determine if that person needs to go to see their doctor to determine if there is a fracture that is present. Something that is kind of unique to the lateral ankle instability is the balance aspect of it, due to the damage to the mechanoreceptors in the ankle with repetitive injuries or first-time injury. So usually I like to use static single leg balance tests on a firm surface with the eyes closed initially. And then I can also use a dynamic test, which is called the Star Excursion Balance Test, and it's demonstrated in this picture off to the right here. We're also going to look at the level of instability in the ankle through our special tests. And those special tests are the anterior drawer tests and the Taylor tilt test. And then we're going to want to look at active and passive ankle range of motion, making sure that the person doesn't have any dorsiflexion limitations common to what we talked about with a plantar fasciitis patient. And then a strength assessment looking at both local and global muscles to the lower extremity. Now, what's our intervention going to look like here for our ankle instability patients? With an acute lateral ankle sprain, we're going to want to progressively bear weight with bracing and external supports, such as a lateral ankle brace or the lace-up brace that Dr. Beatty mentioned. And then we're going to want to dive into a structured rehabilitation program. We're going to want to make sure that we get the range of motion back in the foot and ankle, build some strength, work on stretching, and then also work on neuromuscular training and postural re-education, promoting improved balance and improved proprioception. Similar to what we discussed with the plantar fasciitis case, manual therapy can be implemented to decrease the amount of swelling, as well as to improve range of motion and dorsiflexion, decrease tightness around the ankle that we might be experiencing. And then later on in the treatment progression, we're going to want to focus on getting the person back to their occupation or getting them back to sports, So the use of a brace early in the rehab program for a person getting back to, say, assembly line working or lifting or operating heavy machinery is going to be important. And we're going to implement a work hardening program for that person, exposing them to the work related activities that they may be experiencing later in when they return to work. We want to implement that in the clinic so that they're ready when they return. And then also prevention of a further ankle sprain with prophylactic bracing and proprioceptive balance focus therapy and exercise. For our chronic ankle instability patients, I mentioned before, the dynamic stabilizers are going to be really important. So those are the muscles of the lateral ankle, the muscles of the anterior compartment of the ankle, as well as the proximal muscles of the hip, such as the gluteus medius and gluteus maximus. For these patients, we tend to focus on single leg balanced exercises, stretches and self-mobilization to improve mobility if there's any dorsiflexion range of motion limitations, and then strengthening of the ankle and lower quarter kinetic chain. Braces and taping can be used in sport or occupation setting, but should not be used as standalone intervention. It should be incorporated with a therapeutic exercise program. In addition, manual therapy can be used to improve range of motion as well as reduce pain. So let's take all the, what I talked about, and let's put that towards another case study here. So this case study is a 17-year-old male varsity basketball player. He's also a surfer, and he presents to clinic about 2 weeks following a left ankle inversion sprain during practice. And it's about midway through the season. So his goal is to get back to basketball as soon as possible. And he's had this before. This is his third, or actually fourth, ankle inversion injury. So he complains of a 2 out of 10 pain, a feeling of instability and giving way in the ankle, and weakness, as well as decreased confidence with multiplanar movements such as pivoting, cutting. And as I said before, his goals are to return to sport, both basketball and surfing, once basketball is done, and to improve his confidence with cutting, pivoting, and changing direction. So this person presents with minimal pain and swelling compared to the unaffected side. And as we can see here, his dorsiflexion range of motion is limited on the right compared to the left. So that might be due to not seeking care after his initial ankle sprains or residual from those previous injuries. When we look at a single leg balance on a flat surface, he shows improved scores on the right side compared to the injured side. And there's marked instability and approximately only 85% reach during the star extension balance test compared to the other side. And then with manual muscle testing, we can see that his left side is significantly weaker. And I just want to point out that I had a typo here with the right compared to the left. So the left should be the decreased range of motion, not the right. So initially in our first visit, our initial goals are to be able to play basketball and finish out the season. So we communicated with the school's athletic trainer for getting the individual back to sport and providing him with some return to sport readiness programs, and also discussed the importance of going to the trainer to being taped up for games and continuing to playing on the ankle, with a understanding that we're going to want to focus on improving the proprioception strength of that ankle further down the line. And so we're going to initiate a home exercise program focused on both the ankle and posterior chain, more proximal muscle strength, to try and improve that dynamic stability. So his long-term goals are going to be are to get back to surfing without restriction once the basketball season is over. So I had a discussion with this patient on the expectations and the need for compliance with this home exercise program. So that the expectation that, once we have this chronic ankle instability, it is very common that we are going to have another ankle sprain, and that we may need to implement the use of an ankle brace during surfing, possibly underneath the boot, as well as extreme compliance with his home exercise program on improving the dynamic stability. So that day he left with initial home exercise program of that half kneeling closed kinetic chain dorsiflexion mobilization. And that's seen right here in this bottom right picture, very similar to that knee to wall mobilization stretch that I showed you guys earlier. Ankle band inversion, eversion, and dorsiflexion exercises, focusing on that local strength of the ankle and the extrinsics. And then single leg balance on an unstable surface to promote improved proprioception, as well as improve the dynamic strength of the muscles surrounding the ankle joint. So treatment progression for this patient, we're going to want to make sure that we address that dorsiflexion range of motion as was found in the initial evaluation. So up here in this top right corner, you can see what we call mobilization with movement. So the person's foot is fixed on a box, and then the patient is going to progress forward as an anterior to posterior force is placed on the talus, promoting closed chain dorsiflexion, improvements in that. We're going to want to continue with posterior chain and hip abductor strengthening to promote more proximal muscle strength. So a progression that we might want to use for improving the single leg stability and strength is starting with our STAR excursion balance test that we used as an assessment. We can turn that into an intervention. We can implement three-way lunges, single leg RDLs as depicted here. And then we can perform these exercises from a flat surface, to wearing a shoe, wearing their running shoe, or on a compliant surface such as a foam pad, similar to the one that I'm kneeling on here in this picture. And we can also progress this to single leg hopping and weight acceptance exercises if we're trying to get that patient back to exercises such as, sports that involve jumping, such as this patient with basketball. And then our proprioception and balance exercises are going to play a key role. So single leg balance on a compliant surface with weight circles is a good way to challenge the person's ability to compensate for forces outside their body. And we may even progress that to having them stand on a single leg balance pad and then pushing them in different directions, providing perturbations. For basketball, we can simulate a chest pass while standing on a foam or compliant surface. And for surfing, we may incorporate lunging with a chop or trunk rotation to promote that pronation or supination control of the foot. And then lastly, the last part of their training is going to be sport-specific training for this patient. If it's somebody who's getting back to work, either on an assembly line or lifting heavy boxes, getting in and out of the truck, this last part of the rehab is going to be specific to the occupation of the sport. So for this person, we're going to want to get back to basketball and we're going to want to get back to surfing. So we implemented ladder drills, change of direction drills, and gentle plyometric progression, which included jumping, landing, weight attenuation exercises. And then also balance board and kind of surfing related exercise to promote that pronation and supination control that the patient is going to have to experience when they are out in the water on the surfboard. All right, so that concludes my talk on both the treatment of plantar fasciitis and lateral ankle instability. So just to review our objectives here, we talked a little bit about the relative anatomy and pathomechanics of the foot and ankle injuries, both plantar fasciitis and ankle instability, and discussed the treatment options or what we might expect to perform as far as treatment for the individuals. However, treatments are going to be very selective and individualized for the patient. So things that we talked about here, you might not experience if you're coming in with lateral ankle instability or plantar fasciitis. But hopefully this gave you a good input into what you may experience when you come to see us here at Capitola or San Jose. So that concludes my talk, and I'm ready to answer any questions.
Thank you, Caleb. Such a comprehensive presentation, and I am pretty sure our patients learned a lot of information, a lot of good information. So if anyone wants to review everything, the recording will be available on our website within 24 hours. So please don't hesitate to check it out and share with your friends, family. I am pretty sure a lot of you will benefit from this educational talk. So we are now accepting questions. If you have any, please direct those to us through chat or Q&A button on the bottom of your screen. We'll give a second until the questions come through. There you go. I have a question to start with. What kind of physical therapy is used for ankle to restore motion?
Okay. So usually we will start with a lot of manual therapy. If this is something well, let me back up a little bit. So when we perform our evaluation, we look at what might be causing that range of motion deficit. So that could be a muscle contracture that could be limiting our range of motion. So specifically, I talked about dorsiflexion. So there might be a contracture in the calf muscles, your gastroc and soleus. There might be a buildup of scar tissue inside the joint, in which case we want to break up the scar tissue. We might want to improve the arthrokinematics of the joint. And in that case, say if it was a decreased range of motion from a contracture, we'd want to stretch and also provide manual therapy, soft tissue massage, deep tissue massage to the gastroc and soleus in that complex. If it is something that we find in our examination is more related to the arthrokinematics of the joint or the movement inside the joint, we might use those joint mobilizations that I talked about a little bit earlier. So that would be your ankle anterior to posterior talocrural mobilizations that we would provide. And then from there, I would like to promote independence with that. So the knee to wall mobilizations and this independent stretching are going to be our goal to get back to.
Are you ready for the next question, Caleb, or were you looking
Yes.
for something?
Yep.
Oh, you are. I'm sorry.
No, it's okay.
Is it possible to fix chronic ankle instability through physical therapy?
Yeah, so that's a great question. So with chronic ankle instability, we have a lot of stress that have been put on those ligaments, and everybody's going to be a little bit different. Somebody might have a grade 3 tear where they have completely torn through those ligaments. Some people may have a little bit more laxity, but not have actually torn those ligaments. Either or, we're not going to be able to change the ligamentous laxity. So with chronic ankle instability, we are going to really focus on the dynamic support. So we're going to want to focus on those muscles that surround the joint that provide stability or that dynamic stability, such as the peroneus longus and brevis. We're going to want to make sure that those lateral muscles are really strong. We're going to want to make sure that the muscles in the front of the foot and ankle are strong to control for any type of inversion stress that might be put on the ankle. And we're also going to want to focus on strengthening the hips to decrease the amount of stress that is going through the lower extremity when we are, say, walking, running, or playing sports. So that's our main goal with that chronic ankle instability. If this is something that is persistent for a long period of time, somebody may need a lateral ankle reconstruction, and that is Dr. Beatty's area of expertise after there. And in which case they would have an appointment with him, and then afterwards they would come to us for post-operative rehab.
Oh, okay. Next question. How do you know if you have ligament damage in your ankle?
Okay, good question. So after an ankle injury, so say, for instance, this lateral ankle instability or lateral ankle inversion sprain, you're going to know pretty quickly if you have damaged those ligaments. What you'll experience is you'll experience swelling and pain. There'll be some bruising around the area. And usually the level of swelling, pain, and symptoms is going to correlate with the grade of the sprain. So if you have a grade 1 sprain, you may be able to, get right back up, walk to the side of the court, shake it off, and throw some ice on it. Versus if you have a grade 3 ankle injury or grade 3 injury to the ligaments, you're going to have greater swelling, greater bruising. This is something that you might not be able to put weight on initially, and ultimately, when you come to physical therapy or you come to the doctor, we're going to assess that level of instability or that level of ankle laxity. That is that anterior drawer test that I talked a little bit about in the examination part. The amount of laxity or the amount of translation during that test is going to cue the physician or the physical therapist into how much ligamentous injury there is present.
Thank you, thank you, Caleb. Excuse me. That's all for the questions today. Thank you, everyone, for joining us. We hope you enjoyed the presentations. Like I mentioned before, the recording will be available on our website. And we hope you enjoy your afternoon. Thanks, Caleb.
All right. Thank you very much.